Welcome again to another session in surgery for undergraduates. Today's topic for discussion is inguinal hernia. Inguinal hernia is a very common condition in our patients. It affects children as well as adults alike. This is also a very important topic for the final medical exams. I shall today touch briefly on what inguinal hernia is all about, its symptoms and presentation, the complications, and the treatment. These are 5 common types of hernia that are usually seen in our patients, and among them, the most common is inguinal hernia, which account for about 80% of all cases. A hernia is defined as the protrusion of part or whole of an organ or tissue through the wall of the cavity that normally contains it. An inguinal hernia occurs when an abdominal cavity contents enters into the inguinal canal. In most instances, it is the intestine that enters the inguinal canal through the deep and superficial inguinal rings. Inguinal hernia is the most common type among the hernias, which accounts, as I said, 75 to 80% of all anterior abdominal wall hernias. Its prevalence is around 4% in those aged 45 years and above. Inguinal hernia are more common in males and is the most common hernia also in female, apart from the incisional and femoral hernias. This diagram or picture shows you a right inguinal hernia. There's a swelling, oblong swelling in the right groin extending into the scrotum. The inguinal hernia are classified into 2 broad categories. First, the direct inguinal hernia, which accounts for around 20% of the cases. In this condition, the bowel, usually the intestines, enter the inguinal canal directly through a weakness in the posterior wall of the canal, usually termed the Hasselbeck triangle. This is usually in older patients where there is weakness of muscle due to aging and using. Often it is secondary to abdominal wall laxity and significant increase in intra-abdominal pressure. The second group is the indirect inguinal hernia, which accounts for about 80% of the cases, in which the bowel enters the inguinal canal via deep the inguinal ring. There are 2 contributing factors to this condition. First, congenital in origin. There's incomplete closure of the processus vaginalis and an outpouching of the peritoneum that allows the embryonic testicular descent. Secondly, there is associated weakness of the muscles guarding the deep inguinal ring, which is again age-related and use. This indirect inguinal hernia is more common in children and young adults. In the examination of a patient with inguinal hernia, the location of the deep inguinal ring is a very important part of the examination. In this respect, 3 important landmarks should be taken into consideration. First, the mid-inguinal point. Second, the midpoint of the inguinal ligament. And third, the inferior epigastric artery. This slide shows you the important landmarks that you must familiarize yourself examination of the inguinal hernia. On the left here is the left hemipelvis, diagrammatically shown here. Okay, there are two important lines that you must know. One is the imaginary line from the pubic symphysis right to the anterior superior iliac spine. And the midpoint of this line is known as the mid-inguinal point. Okay, it is the site of the femoral artery and is branched the inferior epigastric artery. The inguinal ligament attaches to the pubic tubercle, which is the upper prominence in the upper lateral edge of the pubic bone. From this pubic tubercle, it attaches to the ASIS. And the midpoint of this ligament is known as the midpoint of the inguinal ligament. It is the site or the landmark for the location of the deep inguinal ring, which is located 2 to 3 centimeters above. The superficial inguinal ring is located here, related to the pubic tubercle, which is above and medial to this tubercle, whereas the femoral ring is inferior and lateral to this tubercle. The occlusion test, which I will describe later, is done by occluding the deep inguinal ring at this point. In this diagrammatic view, again, it shows you the same thing. The blue line is the imaginary line from the ASIS to the pubic symphysis. It is the mid-inguinal point. The midpoint of that is known as the mid-inguinal point. Okay. Whereas the red line indicates the attachment of the inguinal ligament from the ASIS to the pubic tubercle. And its midpoint is known as the midpoint of the inguinal ligament. Okay. Take note that the midpoint of the inguinal ligament is lateral to the mid-inguinal point. The midpoint of the inguinal ligament is the landmark for the deep inguinal ring, which is located at about 2 to 3 centimeters above. And the occlusion test is done by occluding this ring with a finger. The mid-inguinal point is a landmark for the femoral artery and its branch, the inferior epigastric artery, which travels upwards and medially across the lower abdomen on the affected side. As I said, the superficial ring is located above and medial to the pubic tubercle, whereas the femoral ring is below and lateral to the femoral ring. This is another diagrammatic view of these three important landmarks. This is the deep ring. Okay, this is the superficial ring, the weakness in the Hasselbeck triangle. Indirect inguinal hernia comes out, okay, here through the deep ring, and then it enters the inguinal canal. Whereas a direct inguinal hernia comes out through the external, through the posterior wall, which is weakened, posterior wall of the inguinal canal, and the hernia enters into this canal and goes towards the superficial inguinal ring. From there, it is then goes into the scrotum. Okay, so these are the two important marks, and between these two is the inferior epigastric artery, which is a branch of the femoral artery. This inferior epigastric artery goes upwards and medially towards the midline of the lower abdomen. Okay, here this diagram again shows you a direct hernia where the hernia bulges through the thickness in the posterior abdominal wall medial to the inferior epigastric artery, and this then continues the journey towards and exits at the superficial inguinal ring to go into the scrotum. On the right here is an indirect hernia where the hernia exits the stomach and enters the inguinal canal through the deep inguinal ring, which is located lateral to the inferior epigastric artery and vein. It then continues its journey down within the inguinal canal and exits at the superficial inguinal ring into the scrotum. Okay, once it is in the scrotum, then the lump that is described as an inguinal scrotal swelling. That means it extends from the inguinal region into the scrotum. Okay, such swellings you cannot get above these swellings. It is not possible to palpate above and feel the swelling. That means it is continuous. There is no upper border of the swelling. So once there is no, you cannot get above the swelling, it is confirmatory for the diagnosis of indirect inguinal hernia. In the case of truly scrotal mass swelling, such as testicular mass, it is easy to get above the swelling. Okay, and it's possible to palpate above and feel the swelling. So this is unlikely to be due to a inguinal hernia. So if you cannot get above the swelling, scrotal swelling, inguinal hernia is the diagnosis. If you can get above, unlikely to be inguinal hernia. Now we come to the etiology and the risk factors for inguinal hernia. Male, more likely higher risk of developing hernia than female because of the testicular descent part. Increasing age results in weakness of the posterior inguinal canal. Raised intra-abdominal pressure from chronic cough, heavy lifting, chronic constipation, and benign prostatic hyperplasia. Obesity and congenital causes. This is usually the case in younger patients and children. Okay, some thoughts about congenital inguinal hernia, which occurs in childhood, sometimes just immediately after birth in premature children. Okay, these are the cases of inguinal hernia in children, where patent processus vaginalis is the main cause of this hernia. Okay, the processus vaginalis is a part of the precursor to the testicular descent from the retroperitoneum to the scrotum. Okay, the testis is in the retroperitoneum before birth. It travels down to reach the scrotum, and by birth it is already in the scrotum in the majority of children. This is preceded by this invagination of the peritoneum, posterior or retroperitoneal layer here, and that is the processus vaginalis. In most children, this processus vaginalis is obliterated by birth, but in some children, it remains patent even after birth, and this patent processus vaginalis is the cause for the descent of the intestine into the scrotum as an indirect inguinal hernia. The descent of the testis from the retroperitoneum is helped by the gubernaculum, which attaches itself to the scrotum, and by contraction pulls or the testis to the scrotum. Since the evagination of peritoneum is patent, there is fluid and intestine that can migrate into this space. Therefore, in most cases in children, this hernia is usually associated with hydrocele, which can be scrotal or encysted. So the treatment for these cases will be a herniotomy, excision of the hernial sac, and if necessary, to drain out the hydrocele fluid. So that's known as herniotomy plus drainage. Next, we come to the clinical features of inguinal hernia. There are two categories in this group. One is the uncomplicated cases, uncomplicated hernia, where the most common presenting complaint is a lump in the groin. And the features of this lump in the groin, it is reducible. Usually in the early stages, it's reducible. It means it will disappear with minimal pressure or when the patient lies down supine. At times, there is some discomfort, which usually is mild to moderate, which can worsen with activity or standing. Very rarely, uncomplicated hernias produce severe pain. The second group is the complicated case, complicated hernias. And there are three types of complications. The incarcerated, where it unable to be reduced, irreducible, and the hernial contents, especially the intestine, gets trapped in the hernial sac in the inguinal canal or the scrotum. And then they produce pain, tenderness, and erythema. The second, incarcerated hernias can lead to bowel obstruction, and then they can have the signs, clinical features of intestinal obstruction, such as nausea, vomiting, abdominal distension, and inability to pass flatus and stool. And thirdly, strangulation results if the obstruction continues. And this is due to the impairment of blood supply to the intestine or the contents of the hernia. And this occurs, the hernia or the intestine can become infarcted and gangrenous, leading to septicemia and shock, which is a serious complication of hernia, inguinal hernia. Okay, when you examine a patient with any groin lump, the specific features to look for in these patients will be a cough impulse. Remember that an irreducible hernia may not have a cough impulse. So it is important to reduce the hernia and then check for cough impulse. If the cough impulse is positive, then most likely it is an inguinal hernia. Then the location of this groin lump is important in the inguinal region. If it is superior and medial to the pubic tubercle, or in case of inguinal hernia, or it is inferior and lateral to the pubic tubercle in femoral hernia. Okay, so the location of this lump, the neck of this lump, will help to determine, reveal whether it is a inguinal or femoral hernia. And thirdly, check for reducibility, either spontaneous or minimum pressure. Ask the patient to lie down and observe, see whether the lump disappears. If it disappears, then it is called reducible hernia, and it confirms the diagnosis of inguinal hernia. If you cannot reduce spontaneously, then apply some mild pressure to the lump to see whether it will be reduced. If it's an inguinal scrotal lump where the hernia has made its way into the scrotum, then see whether you can get above it or otherwise. If you cannot get above it, then it confirms the diagnosis of inguinal hernia. If you can get above the lump, then most likely it is a local cause in the testis or its covering, like a hydrocele or a testicular mass, and unlikely to be a inguinal hernia. Now we come to how to differentiate between inguinal hernia, whether it's direct or indirect, clinically. This is a very important test which you are expected to do in exams. And this is known as the occlusion test. Okay, this is the occlusion test. There are 3 simple steps to do this procedure. First, reduce the hernia with the patient lying down. Place finger pressure over the deep inguinal ring, as we know it is located at the midpoint of the inguinal ligament, and ask the patient to cough. If the hernia protrudes despite occlusion of the deep inguinal ring, this indicates a direct hernia. If it does not protrude, it indicates it is an indirect hernia. Okay. However, having said this, caution must be taken. This assessment clinically is often seen as unreliable, especially in patients who are obese and difficulty in locating the landmarks which I mentioned. And the only definite method to differentiate them is at the time of surgery. Okay, next we come to differential diagnosis of inguinal hernia or a mass confined to the groin or extends into the scrotum. The first scenario, confined to the groin. So these are the common differential diagnoses. The most common ones are inguinal lymphadenopathy, localized lesions like lipoma, sebaceous cysts, and groin abscesses. Rarer differential diagnoses include femoral hernia, saphenous varix, and aneurysm of the internal iliac artery. If the swelling extends into the scrotum, as I showed you in the diagram earlier, it can be lesions within the scrotum, such as hydrocele, varicocele, or testicular mass. Now, what are the investigations that should be done for these patients with hernia? Okay, diagnosis of hernia is basically a clinical one. Okay, it's a clinical diagnosis. Rarely we do need any other investigations to confirm the hernia. If at all, the imaging methods that are used is ultrasound. This is necessary in patients where the diagnosis is uncertain, or you need to exclude some other pathology, such as testicular mass in a patient with the inguinal scrotal mass. Apart from ultrasound, sometimes you may need a CT scan as well, but this is rare. Rarely you need a CT scan to diagnose a patient of inguinal hernia. Abdominal X-ray, plain X-ray abdomen, is sometimes useful, especially in complicated cases where they suspect intestinal obstruction. Okay, you need to do a supine and erect film which will show multiple air fluid levels and a distended small bowel. Now we come to the management of inguinal hernia. I must emphasize that definitive treatment is surgery. Okay, surgical repair is the definitive treatment for inguinal hernia, both direct and indirect hernia. Okay, what are the indications for surgical intervention? The surgical intervention is for symptomatic inguinal hernia, and the patient has got pain, discomfort, or the swelling is big and causing him discomfort and hampering his activities. Secondly, when they develop complications, incarceration, obstruction, or strangulation. When these complications develop, there is some urgency in the treatment, surgical treatment of these patients, especially strangulation, which is a very serious complication which must be treated with surgery as an emergency procedure. The risk of strangulation is about 3% per year with an inguinal hernia. Okay, the next is conservative treatment. Conservative treatment can be carried out on patients who do not have any symptoms, but we must bear in mind the potential for complications is higher, especially in indirect inguinal hernia. Patients who are old, sickly, and not fit for surgery may be considered for conservative treatment. Otherwise, all other patients should be considered for surgical treatment. In summary, this summarizes the treatment for direct and indirect hernia. For direct hernia, there is conservative treatment if the patient is not fit for surgery. Otherwise, if he develops complications, surgical treatment should be considered as soon as possible. For indirect inguinal hernia, surgery is the mainstay and the treatment of choice, unless there is some contraindication to surgery in that particular patient. The conservative treatment consists of the following: reducing intra-abdominal pressure such as training, weightlifting, getting treated for the constipation or the BPH that causes difficulty in passing urine, use of compression belts or truss, okay, to prevent the hernia from protruding, and also getting treated for cough, especially patients with aggressive and chronic cough. Okay, these are pictures showing you the hernial compression belt, okay, which can be worn by patients, okay, especially when they are walking or standing or working, and this can be removed while they are lying down or sleeping. This is a belt here. Next, we come to the surgical repair of inguinal hernia, which can be done either by open repair or laparoscopic repair. In the open repair, the earliest procedure to be done is known as herniorrhaphy, okay, or it's called the Bassini repair. In this repair, non-absorbable sutures in the form of a loop is used to strengthen the posterior wall of the inguinal canal, whereby this reinforces the wall and prevents the herniation of the contents. This procedure is associated with a significant recurrence rate over the first 5 years. Hernioplasty is nowadays preferred. This is known as the mesh repair, and the technique used is Lichtenstein technique. A mesh from an inabsorbable material and inabsorbable synthetic material like Prolene is used to reinforce the posterior inguinal canal. this is not only is an easier operation, but it also reduces the recurrence rate. These can be performed under general anesthesia, spinal, or local anesthesia, depending on the fitness of the patient. In children, where the hernia is congenital due to a patent processus vaginalis, the operation done is known as a herniotomy. Okay, herniotomy is the excision of the hernial sac, and by excising and ligating it, you are obliterating or removing the potential space of the which is provided by the processus vaginalis, and thereby eliminating the space for further recurrence of the hernia. At times, very often, it is to be associated with drainage of an hydrocele, because most of these congenital hernia occur in very small children and is associated with hydrocele as well. Okay, this is a open mesh repair. Okay, this is the spermatic cord which is retracted away to expose the posterior wall, and here is your deep ring. So there's a mesh placed in the posterior wall covering the deep ring as well, and this is then sutured all around. This reinforces and strengthens the posterior abdominal wall and prevents or giving way to further recurrence of the hernia. Okay, this is a mesh. Normally we use a Prolene mesh. In fact, nowadays there are so many prosthetic material that can be used as meshes. Okay, this is placed underneath here. The next one is laparoscopic repair. These days, minimally invasive surgery or laparoscopic surgery has become the ideal treatment or the preferred treatment because of the less pain and faster recovery. So laparoscopic repair is indicated for bilateral hernias, okay, recurrent inguinal hernias, where repair is associated with some risk to injury to the local structures. Patients for high risk of chronic pain, and I think this patient may develop chronic pain, the laparoscopic method would help to reduce this risk. And in some females where we cannot rule out a femoral hernia, so a laparoscopic method will be more preferable to deal with such patients. There are two types of repair. One is known as a total extraperitoneal repair, TEP, or transabdominal preperitoneal repair, TAPP. Okay, both are equally good and effective in preventing recurrences, reducing the pain, and also cost effective. In general, laparoscopic repairs are may be associated with longer operative times, but quicker post-operative recovery, fewer complications, and less post-operative pain. Okay, this is a picture showing you the laparoscopic operation. This is the internal ring where the hernia has gone in. So this hernia is reduced and a mesh is placed over it. Okay, here a mesh is placed over it. And this mesh is anchored all around the periphery with staples. Okay, this is the entry ports, free entry ports. And this is, as I said, this is the deep inguinal ring through which the hernia protrudes into the inguinal canal and scrotum. So this is a simplified treatment algorithm for inguinal hernia. You've got primary unilateral inguinal hernia, which can be done with open method. If there's risk of chronic pain, then you can opt for laparoscopic repair. In some females where you think you may have femoral hernia, then a laparoscopic repair will be more ideal. Primary bilateral, go straight for laparoscopic repair. Recurrent inguinal hernia, go straight for laparoscopic repair. Complications of hernia, which I've already mentioned: incarceration or irreducibility, where the contents get trapped in the inguinal canal or the scrotum. Strangulation, where there's cut-off of the blood supply due to pressure. Strangulation at the neck of the inguinal hernia. This is especially so for indirect inguinal hernia, where the strangulation occurs at the deep ring. The other complication is bowel obstruction. Patient presents with abdominal distension, vomiting, nausea, and constipation. Okay, this is a loop that was in the hernial sac, which is strangulated at the neck. And here, because of ischemia, the bowel becomes infarcted, and this needs to be resected. Okay, this is a strangulated hernia, a complication of inguinal hernia. Postoperative complications of hernial repair. Those in green here are the most common complications. Pain, bleeding leading to bruising and hematoma, especially scrotal hematoma, infection due to the placement of a foreign body mesh, urine retention. The recurrence is another important complication, which roughly occurs approximately 1% within the first 5 years of surgery. Chronic pain, okay, persists for 3 months after the hernia repair, can occur up to 30% of patients, and disabling pain in about 2% of patients. Damage to the vas deferens and testicular vessels leading to infertility is another possible complications, but usually it is not common. Then we come to the emergency management of hernia. Normally hernia, uncomplicated, you do as an elective operation. Once there are complications, serious complications, then you have to go for emergency operation, especially for strangulation of the intestine. Strangulated hernias, okay, can lead to bowel infarction and gangrene, perforation, and septicemia. So strangulated hernias must be done as an emergency, okay, immediately as soon as the patient is stabilized. Fluid replacement, antibiotics, and then taken to OT for exploration. And the surgery involves surgical exploration, reduction of the hernia, which may result in spontaneous revascularization, or if necessary, bowel resection and anastomosis if the bowel is already infarcted. Subsequently, the mesh repair of the hernia is done, and antibiotics cover is very important in strangulated cases. And also, I must stress the importance of fluid and electrolyte replacement in patients with strangulation. So what are the key take-home points from this lecture? Okay, first, an inguinal hernia can be classified as direct or indirect. The diagnosis is a clinical one and only warrants further investigation if there is diagnostic uncertainty. In direct inguinal hernia, surgery must be done as soon as possible. Direct inguinal hernia can be treated conservatively unless complicated. Conservative treatment, especially for patients who are not fit for anesthesia and surgery. Most cases of hernia are repaired via open approach unless it's bilateral or recurrent. But today, laparoscopic repair is becoming more and more a standard procedure compared to the open approach. We come to the end of today's session on inguinal hernia. As I said, it's a very common condition in our practice. It's also a very important topic for examination for the undergraduates. I hope my talk today would have enhanced your understanding of this topic, and I hope to see you again in another session in the near future. I will now leave you with a short and meaningful quotation here for your reflection. Thank you.